So good morning all. Today we shall discuss about panoramic radiography. Panoramic radiography is a technique producing the single image of facial structures including maxillary and mandibular dental arches and their supporting structures. It was introduced by Numato and Patero, and Patero is considered as the father of panoramic radiography. Indications of OPG: for visualizing the maxilla and the mandible in one film, to evaluate multiple impacted teeth and supernumerary teeth, to evaluate eruption sequence and development of jaws, to detect any pathology involving the jaws, to examine the extent of a large lesion, to evaluate traumatic injuries, excellent for comparison of right and left side structures, for radiographic examination of patients with limited mouth opening, to identify the diseases of TMJ, and to evaluate the elongation of styloid process. Disadvantages: the images are not so sharp in panoramic view when compared to IOP. It shows superimposition in the premolar area. Structures in the anterior region may not be well defined in an OPG. OPG cannot be used as a substitute for an intraoral film. Now, the diagnostic regions or zones in an OPG for interpretation, it is divided into 6 zones. Zone 1 is the maxillary and the mandibular teeth. Zone 2 is a midface region which consists of the maxillary sinus, nasal septum, nasal fossa. Then zone 3 is the body of the mandible. Zone 4 is a temporomandibular region, that is the condylar head, coronoid process. Zone 5 is the ramus and the cervical spine region. And finally, the zone 6, that is the hyoid bone. Principle of OPG: the X-ray tube and film rotate in opposite direction about a fixed plane which remains in focus. Focal trough is a 3-dimensional imaginary zone which is horseshoe shaped, where the patient is supposed to stand while taking an OPG. Technique and positioning: the patient should be asked to remove all the foreign objects. Patient should be explained about the equipment movement. Patient should be positioned accurately within the machine. Patient should be instructed to press the tongue against the palate, and the normal exposure time 18 seconds, 70 to 100 kVp and 4 to 12 mA. Take the time to explain the apparatus and film cassette rotation to the patient. Set the appropriate exposure data. Have the patient remove all jewelry from ears, hair and neck. Demonstrate the bite holder for the patient so that he or she should practice biting in centric relation. Have the patient practice proper tongue position, and depending upon the indication, either remove patient processes or leave them as such. Apply the protective lead apron to the patient and utilize appropriate barrier techniques. Now, 3 main images are formed in an OPG. One is a real image, the other one is a double image, and the third one is a ghost image. All the objects or images we see in an OPG comes under these 3 headings. What is a real image? Real images are formed when the object is located between the X-ray receptor and the center of rotation. Double images are objects that lie posterior to the center of rotation and that are interpreted twice by the X-ray beam to form the double image. Example: hyoid bone, epiglottis, and cervical spine. Ghost images are formed when the object is located between the X-ray source and the center of rotation. Characteristics of ghost image. The ghost image has the same morphology as its real counterpart. Ghost image appear on the opposite side of the radiographic part from its real counterpart. Ghost image appear higher than its counterpart, and ghost image is more blurred than its normal image. Now, the artifacts that we usually see while taking an OPG. If the head is tipped too far forward, the anterior teeth appears minified or smaller in horizontal direction. If the teeth is placed too far posterior, if the teeth are positioned behind the notches in the bite stick, the anterior teeth will appear wider and it will be blurred. It will be less sharp than normal. If the teeth are behind the notches, they are farther from the film, resulting in more magnification horizontally. That is a widened image. Being out of the focal trough makes the images less sharp. Deviation in sagittal plane. If the patient's head is deviated in sagittal plane, one side of the image or the OPG will be minified and the other side will be magnified. Movement of the head during exposure will produce an image like this, where the inferior border of the mandible will not be sharp. Jerky movement of the cassette is also a type of artifact. Coming to anatomy of OPG. So these are the various anatomical landmarks that can be seen in a panoramic image. So here we can see the pterygomaxillary fissure, and here we can see the posterior border of maxilla. Then we have the maxillary tuberosity, the maxillary sinus, then floor of the maxillary sinus. Floor of the maxillary sinus can be seen here. Then medial border of the maxillary sinus or the lateral border of the nasal cavity. Then we have the floor of the orbit here. Then the infraorbital canal, which is seen in the floor of the orbit. Then we have the nasal cavity. This is a nasal cavity where we can see the nasal septum, the nasal fossa, then the wall of the nasal cavity. Then we have the floor of the nasal cavity. Here the floor along with the floor of the hard palate also can be seen at this region. Then we have the anterior nasal spine, then the incisive foramen region. This is the hard palate region, hard palate, this shadow, hard palate, or the floor of the nasal cavity. Then we have the zygomatic process of maxilla. Then we have the zygomatic arch. This is a zygomatic arch. Then the articular eminence. Then external auditory meatus, this side also. Then styloid process. Styloid process, here is a region. You can appreciate in this line diagram. Then the mandibular condyle, condylar head. Then we have the coronoid process. Then we have the sigmoid notch. Then the posterior border of the ramus here. Then angle of mandible. We have the hyoid bone. This is the hyoid bone. Then the inferior border of mandible. Then the mental foramen. Then the mandibular canal, both sides. Then the cervical vertebrae. Usually the cervical vertebrae shadows will be overlapped in the anterior region. So we cannot interpret in the anterior region using an OPG. Then we have the epiglottis. This is the epiglottis shadow which can be seen overlapped over the hyoid bone shadow. Now, to conclude, the evaluation and interpretation of the panoramic radiograph is a challenging task, but an in-depth knowledge of the normal anatomic structures always helps to distinguish them from the pathologies, proving the fact that one recognizes only what one already knows and understands. Thank you.